Hello and welcome to the ASCO Guidelines Podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Sharon Giordano from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Nancy Davidson from Fred Hutchinson Cancer Research Center and the University of Washington in Seattle, Washington, co-chairs on systemic therapy for advanced human epidermal growth factor receptor 2 positive breast cancer, ASCO Guideline Update. Thank you for being here, Dr. Giordano and Dr. Davidson.
Thank you.
Thank you for having us.
First, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guideline in the Journal of Clinical Oncology. Dr. Giordano, do you have any relevant disclosures that are directly related to this guideline topic?
No, I do not.
Thank you. And Dr. Davidson, do you have any relevant disclosures that are directly related to this guideline topic?
No, I do not.
Thank you. Then let's talk about the content of this guideline update. So first, Dr. Giordano, what prompted an update to this guideline on the systemic therapy for advanced HER2-positive breast cancer, and what's the focus of this update?
So we were prompted to update the guidelines for HER2-positive metastatic breast cancer because several new studies have been presented and published, which are really changing our standard of care approaches. We have new therapies and new combinations that have resulted in improvements in progression-free survival and in overall survival for this patient population. Given the clinical importance of these new studies, we felt that an update of the treatment guidelines was clearly needed. Overall, the focus of our update is really in the title, so it's systemic therapies for advanced HER2-positive breast cancer. And specifically what we were focusing on is updating the recommendation for second-line therapy and then adding multiple new options for systemic therapies for third-line and greater treatment.
Great. Thank you for that overview. So then I'd like to review the updated recommendations of this guideline for our listeners. Starting with Dr. Davidson, what is recommended for first-line therapy for patients with advanced HER2-positive breast cancer?
So that was the part of this guideline that really did not change. In the previous iteration and in the current iteration, we felt that the evidence suggested that a combination of pertuzumab and a taxane should be the first-line treatment for individuals with metastatic HER2-positive breast cancer, unless they have some sort of contraindication to the taxanes. The evidence supporting that is very strong. The trial that supported this continues to be updated and continues to show benefit. So that's a very high level of evidence, and our recommendation on this was extremely strong.
Great. And then following those first-line recommendations, Dr. Giordano, what is recommended for second-line treatment for these patients?
So we did change our recommendation for second-line treatment for HER2-positive patients. The current new recommendation is, and I quote from our guideline, if a patient's HER2-positive advanced breast cancer has progressed during or after first-line HER2-targeted therapy, and the patient has not received trastuzumab deruxtecan, clinicians should recommend trastuzumab deruxtecan as a second-line treatment. So as I said before, this recommendation is a change from our prior second-line recommendation. Previously, we had recommended TDM1. So this change is really, I think, one of the most important changes to the guidelines with this update. We made the recommendation based on the initial presentation of the results of the Destiny Breast03 trial, really given the magnitude of the benefit that was seen in this study. And the manuscript, I would note, was published this month in the New England Journal of Medicine. Overall, the study showed statistically significant and highly clinically meaningful reduction in progression-free survival. So just to give you some of these numbers, to kind of give you a sense of how big the impact was. So 76% of patients who were treated with trastuzumab deruxtecan versus 34% of patients treated with trastuzumab emtansine were alive and without disease progression at a year, with a hazard ratio of 0.28. The response rates were also quite impressive, with 80% versus 34% response rates. And the overall survival data are still immature, but do favor treatment with trastuzumab deruxtecan, and that hazard was 0.55. So I will note, though, that toxicity was a bit higher with the new drug, with trastuzumab deruxtecan. So any grade adverse events were 98% versus 87%. And then if you look at grade 3 and 4 drug-related adverse events, it was 45% versus 40%. I think of note, rather than just kind of the overall numbers, though, one thing that clinicians need to be aware of is the risk of interstitial lung disease with this new drug. And this occurred in about 10% of treated patients in this study, although only 1%, or I think it was 2 patients, had grade 3 or higher pulmonary toxicity. So this is a toxicity that is specific to this drug that clinicians do need to be aware of.
I think the other thing on that, Sharon, is that the incidence was lower in the Destiny Breast-03 trial than it had been in some of the really early studies of this agent. So that should be reassuring to us, although, of course, it doesn't mean that the side effect doesn't happen. We have to take note of it.
Now, that's a great point. It definitely was lower than we'd seen before, so a little bit of a relief, but still there.
Great. Thank you both for reviewing that data. I appreciate the overview. So then following those recommendations for second-line treatment, Dr. Davidson, what are the recommended options for third-line therapy for patients with HER2-positive advanced breast cancer that has progressed on second-line or greater HER2-targeted therapy?
Well, of course, this is the area where there's been considerable change as well, and that's because of the wealth of new anti-HER2 agents that Dr. Giordano talked about earlier. So we had a variety of recommendations where clinicians and patients can make decisions about how to proceed. I think certainly one of them is that if the patient did not receive trastuzumab emtansine, TDM1, in the second line, as we just talked about, our new recommendation would be that they would not, that they would receive trastuzumab deruxtecan. So you could offer TDM1 in that setting. And that's a new recommendation for us, and the strength of the recommendation is quite high. Another agent that's come along that's very exciting is tucatinib, one of the small molecule inhibitors. And we think that that's also an alternative, that one could think about tucatinib in combination with trastuzumab and capecitabine. Again, nice activity and pretty strong recommendation based on randomized clinical trials. And then finally, if for some reason the patient didn't receive the trastuzumab deruxtecan in that second line setting and they're now in the third line setting, that would be a very reasonable agent for them as well. So those are all pretty strong recommendations, and I think the choice of which to proceed with depend a little bit on the decision making between the patient and the doctor about the mode of administration, the side effect profile, what seems the most appropriate. And it might be more one of the order of the recommendation as opposed to saying this one but not that one. It might be pick this one next and know that you'll be able to return to some of these in the future. Now, there are a lot of other possibilities here. We already had available to us neratinib and capecitabine. That continues to be part of the portfolio. And we also had lectinib and capecitabine, also part of the portfolio. Other combinations of chemotherapy with trastuzumab could be considered. A new agent called margetuximab with chemotherapy, which has also come onto the market. And of course, there's the possibility of thinking about these anti-HER2 agents in the context of endocrine therapy for those patients who have estrogen receptor positive breast cancer as well. And new information suggesting that you might in some cases even think about one of the CDK4/6 inhibitors in the context of trastuzumab and fulvestrant. So lots of possibilities here that patients and doctors can weigh. And again, think about the order of administration as opposed to selecting for, against, or the other. I do think, though, that the leading contenders at the beginning are going to be TDM1 or trastuzumab deruxtecan if that hasn't been used, or a tucatinib-based combination. Those would be my personal preferences.
Great. Thank you for reviewing those options and describing where a patient might receive these during their treatment.
I might be interested in Dr. Giordano's thoughts on that. How would you stack those up?
Yeah, well, like you said, I think it does depend on what the patient's been treated with previously. I mean, certainly TDM1 or trastuzumab deruxtecan if they haven't had those agents. Otherwise, I think the data from the tucatinib, trastuzumab, capecitabine regimen is pretty impressive, as it did show an overall survival benefit. And as you know, I think that regimen is also really interesting because it does seem to have some efficacy for patients with brain metastases. That actually has a very nice advantage. And then the other ones, I think it just sort of depends on what they've seen previously, what side effects they may be experiencing, and kind of other quality of life issues. I don't see that there's a clear way to sequence the other ones since most of them haven't really been directly compared head to head against each other.
It seems like it may be an individual discussion between clinicians and patients then at that level. So then, Dr. Giordano, following that, how will this guideline impact clinicians and what should they know as they implement these updated recommendations?
But I think the bottom line is really that clinicians are now going to have more options for the treatment of HER2-positive advanced breast cancer, which, is fantastic news to have all these different choices and options for our patients. To me, I think probably the most important changes and recommendations, again, are the addition of trastuzumab deruxtecan in the second-line setting, just given the very impressive clinical benefit that's seen with that drug. Or, as Nancy mentioned, in the third-line setting, if patients, for some reason, haven't received it previously. And then I also think, as we talked about, the tucatinib combination is really an exciting new combination that does seem to have significant clinical benefit. I think that clinicians will need to, be aware that that might be an option for patients with CNS metastases that are progressing. And also just to be aware, as we mentioned before, about the risk of the interstitial lung disease with trastuzumab deruxtecan. But it's really encouraging to me to have such a long list of drugs and combinations that we can use to treat our patients.
Excellent. Those are great points. So then finally, to wrap us up, Dr. Davidson, in your view, how will these guideline recommendations impact patients with advanced HER2-positive breast cancer?
Well, Brittany, I think one thing we hope, of course, is that those patients will cumulatively have a longer survival and a better survival as a consequence of all of these new insights that we've been able to make. I can imagine it would be maybe a little confusing to patients that there are so many things that they might potentially be able to choose from. But this is one where I think that the larger the panel of agents that you have available to you, the happier it is. So I hope that patients are going to look at this as an opportunity for partnership with their oncologists to try to figure out, of all these possibilities, what's the best one for me now? And they're going to have the comfort of knowing that there'll be other things that they can fall back on in the future if need be. And that hopefully these things will improve outcomes, and again, without excessive toxicity. I guess the last thing I'm going to hope that clinicians and physicians will remember is that we've made a lot of headway here, but our results are not perfect. And so right now, we're able to change these guidelines today, because of clinical trials that have been put together in the last several years and successfully implemented. And I hope that we're going to continue to do that, because until we get to a point where the survival from HER2-positive breast cancer is 100%, we've got work to do. And so there are going to be other new clinical research strategies, and I hope that doctors and patients will take advantage of those whenever possible.
Absolutely. Both hoping for longer survival and better quality of life, and looking forward to more clinical trials to give clearer answers. So I want to thank you both so much for your time today and for all of your work on updating these guideline recommendations, Dr. Davidson and Dr. Giordano.
Thanks, Brittany.
Thank you so much.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/breast-cancer-guidelines. There is a companion guideline update on the management of advanced HER2-positive breast cancer and brain metastases, also just published in the Journal of Clinical Oncology and on asco.org. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.